Good evening, everyone. Thank you so much for taking the time to be with us tonight. We're very grateful for your support. I'm David Dodick, and I'm the chair of the American Brain Foundation, and I'm a neurologist at the Mayo Clinic in Arizona. The American Brain Foundation is very proud to be stepping into the role as the national standard bearer for brain disease research. Our vision is a life without brain disease, and our strategy to achieve that vision is to support research that will uncover the common biological mechanisms that give rise to several different diseases. And by doing this, we believe that when we cure one, we will cure many. Our partner in this endeavor is the American Academy of Neurology. That partnership puts us in a very unique position to identify and support only the research that will be most impactful and lead to advances in treatment and cures. This is because it's the world's largest association of neurologists and neuroscientists, and therefore houses the nation's, and indeed the world's, brain trust in all of the neurological diseases. So tonight we're going to be talking about Alzheimer's disease. Alzheimer's disease is the most common form of dementia, affects about 6 million Americans. That's about 1 in 10 people over the age of 65. And as the number of older Americans grows rapidly, by 2050, it's projected that up to 14 million people could have Alzheimer's disease in the United States, unless we have a medical breakthrough that prevents, slows, or cures the disease. So tonight, we're very fortunate to have truly one of the world's leading experts and researchers in Alzheimer's disease. Dr. Ron Peterson is a member of the board of the American Brain Foundation, and he's a professor of neurology at the Mayo Clinic in Minnesota. And I'll embarrass him a little bit by giving you a little bit of his background. He directs the Mayo Clinic Alzheimer's Disease Research Center and the Mayo Clinic Study of Aging. He chairs the Advisory Council on Alzheimer's Research, Care, and Services for the National Alzheimer's Project since 2011. He is a member of the National Advisory Council on Aging. He's on the board of directors of the Alzheimer's Association since 2008, and he's a member of the World Dementia Council since 2014. He's won many prestigious national and international awards for his research and his contributions to our current understanding of Alzheimer's disease. And he's authored an unbelievable number of publications, over 700, as well as 5 books. So we're very lucky to have Dr. Peterson tonight. I can't think of anyone better to talk to us about current trends in Alzheimer's disease research and what's giving us hope. Dr. Peterson.
Thanks very much, Dave. I certainly appreciate the opportunity to visit with you tonight and with the folks from the American Brain Foundation on Alzheimer's disease. And if I could, actually, if I can advance my slides, which is becoming, there we go, very good. I think this is, as you've outlined, Dave, almost a crisis in this country for Alzheimer's disease, and in fact the world. In fact, the developing parts of the world are at greatest risk for Alzheimer's disease, since the aging of those countries really is the leading risk factor for developing Alzheimer's disease. And consequently, our understanding of it becomes increasingly important. So back when I was training, and perhaps when Dave was training as well, you had the picture of individuals with aging as either being cognitively normal or having developed dementia. Now, what's dementia? Dementia is I'm not remembering as well as I used to, thinking as well as I used to, and it's affecting my daily function. So you're either normal or you had dementia. But over the years, we came to realize that this is really a continuum. And there's no hard and fast demarcation between normal and dementia. We came to recognize this intermediate condition called mild cognitive impairment, which means that, maybe you're not remembering as well as you used to, and maybe not as well as you ought to, but otherwise you're functioning pretty well. You're still doing all the things you used to do. You're paying your bills, you're driving, doing your taxes, but your memory is not quite what it used to be. So we've come to appreciate that this is really a continuum of normal aging, which sometimes will then evolve into mild cognitive impairment and may go on to develop dementia. In 1984, there was a landmark publication that outlined the criteria for Alzheimer's disease. And back then it was called a clinical pathologic correlation. What that meant is that somebody had the clinical condition of forgetfulness and maybe some other cognitive domains, language, attention, problem solving were involved, and it was affecting your daily function. We called that dementia. Then the doctor did a bunch of rule out stuff, making sure that you didn't have a brain tumor, you didn't have hydrocephalus, you didn't have strokes that were accounting for this condition. And if you didn't find anything, then you said it was probable Alzheimer's disease. But you couldn't say definite Alzheimer's disease until the person passed away, had an autopsy, you looked under the microscope at the brain, and you saw plaques and tangles. Plaques made of this protein called amyloid, tangles made of this protein called tau. Then you could say it was definite Alzheimer's disease. But over the years, we came to appreciate the fact that we learned a lot about this disease. And we could now identify some biomarkers. Biomarkers are medical indices that something's going on in this condition. The best known is cholesterol is a predictor of heart disease. Well, now in Alzheimer's disease, we could look inside the brain with imaging studies and see these proteins in the brain. We could do a lumbar puncture and see these proteins in the cerebrospinal fluid that surrounded the brain. So we could be more precise now that this clinical picture, be it MCI, be it dementia, was in fact due to Alzheimer's disease. But even in 2011, it was still a clinical pathologic correlation, clinical picture with some of those biomarkers. Just a couple of years ago then, another expert group was formulated that really came to the decision that maybe we should define Alzheimer's disease on its biologic basis, meaning that we look for the presence of amyloid, we look for the presence of tau in the brain. If they're there, the person has Alzheimer's disease, irrespective of what the clinical picture looked like. You could even be normal. You could have mild cognitive impairment, you could have dementia, but Alzheimer's disease now is defined biologically. This is a research proposal. It's out there for investigation. It needs to be validated. It's not in the clinic yet. But this was a major departure because now people are saying, maybe we should look at Alzheimer's disease like we do look at cancer. If you have a breast biopsy, it's positive, you have breast cancer. You have a prostate biopsy, it's positive, you have prostate cancer. Maybe we should say, okay, Alzheimer's disease, if you have those biologic features, you have the disease. Again, the clinical criteria, the clinical features are important for staging, but not for the definition. So this is being now investigated in a research framework, and I think that we're probably going to adopt that proposal coming down the road. So that ultimately a person could be cognitively unimpaired, could be MCI, could be dementia, but if you have the biologic features of the disease, you in fact have Alzheimer's disease. So biomarkers have become very important in investigating the underlying cause of the clinical symptoms and in fact in the definition of the disease. So what do we mean by these biomarkers? I'm just going to give you some examples of a couple of imaging biomarkers. Again, they could be verified in the cerebrospinal fluid as well. So in the neuroimaging perspective, if we do a PET scan, which is positron emission tomography, looking for the presence of the amyloid protein, we will see pictures like this. This is looking at the brain from the top down. On the left, we have somebody who's cognitively normal. The yellow-green is sort of non-specific. That's a negative scan. In the middle picture, we have amnesic mild cognitive impairment. The redness now indicates that this person with mild cognitive impairment does have the amyloid protein in the brain. On the right, we have somebody with full developed dementia due to Alzheimer's disease. A lot of the redness indicates that this is in fact Alzheimer's disease, contributing to the symptoms of this person at the dementia stage. But this is sort of idealized. When you go out into the community, you see all combinations. So in the left-hand column in the upper left, we see somebody who's cognitively normal, but in fact has a negative scan. In the bottom left, we have somebody who's cognitively normal and has a positive amyloid scan. All that redness means the person has the amyloid protein in the brain. In the middle column, we have somebody with mild cognitive impairment, forgetfulness, but a negative amyloid scan. The bottom, we see somebody who has amnestic mild cognitive impairment with a positive scan. Bottom right, somebody at the dementia stage with a positive scan. So this now raises a lot of questions for us. What about the person in the bottom left-hand corner? Is this individual going to develop cognitive impairment in his or her future? And when is that? Is it today, tomorrow, 5, 10, ever in this person's lifetime? We don't know for sure. Person in the bottom of the middle says, I have mild cognitive impairment. I have the Alzheimer's substrate in the brain. Will I progress on to the dementia stage? Probably, but when? Again, today, tomorrow, 5 years from now. So nevertheless, these biomarkers now have allowed us to look at one of the proteins in the brain, amyloid. The other protein that defines Alzheimer's disease is this tau protein. And similarly, now we're looking at 2 PET scans from the front on. The scan on the left shows a clinically normal person. The yellow stuff in the middle is nonspecific. That's a negative scan. But on the right-hand picture, we see somebody with Alzheimer's disease dementia. The redness, the yellow, now indicates that this person has the tau protein in the brain. So if this person has a tau protein and also has the amyloid that we saw on the earlier scans, this person biologically has the Alzheimer's disease substrate in the brain. So from a diagnostic perspective, we can be pretty precise these days that this clinical syndrome may or may not be due to underlying Alzheimer's disease. On the treatment side of the house, I think we're a bit more impoverished. We're working on it. We got a lot of work to do, but we're not there yet for the treatments to get at the underlying nature of this disease. Here's a picture of this is an older picture, but a whole bunch of drugs that are under development. In the inner circle, we have phase 4, then we have phase 3, 2, and 1, preclinical stages. So compounds that are being looked at by various academic institutions, various companies, trying to get at the underlying features of this disease. Very, very active area of research. If we look at it from a conceptual perspective, if we go from the bottom left to the bottom right, disease progression, we can look at various stages of intervention. Primary prevention, trying to prevent the biology of the disease. Secondary prevention, there's a little bit of the biology. We're trying to prevent the clinical progression, and then treatment of the dementia stage. So the clinical state that corresponds then is normal. Preclinical AD means the person is cognitively normal, but does harbor some of those underlying biologic features of the disease, MCI and dementia. Here's what's going on in the brain. No disease, no symptoms, various stages of pathology progressing in the brain. And here's what we plan to do to try to attack the disease process at these various stages of the disease. So we're trying to look at the disease from its totality. On the right-hand side, we have people with fully developed dementia, the symptoms of the disease. We need to treat that aspect of the disease. But what we'd really like to do is move back to the left in this diagram, maybe to mild cognitive impairment, ultimately to preclinical disease, and even normal to try to prevent the disease from progressing. And I think this is in the wheelhouse of the investigators in the disease right now, and I think this is on the horizon that we'll be able to achieve these goals. But is that the end-all be-all? Does Alzheimer's disease encompass everything that happens in aging with respect to cognition? Probably not. It's an important piece, but probably not. So if you look at the clinical spectrum in the middle, cognitively normal, MCI, and dementia, what could impact that? Well, the amyloid beta protein is a factor. The tau protein that we've seen is a factor, but there are other features. Something called alpha-synuclein. This can produce Lewy bodies, which are seen in Parkinson's disease. Parkinsonism can coexist. with Alzheimer's disease. Another protein called TDP43 can in fact produce forgetfulness in the memory parts of the brain, just like Alzheimer's disease can. So it's another common feature that we see in aging. Vascular disease, little blood vessels that close off that may in fact impact the function of the brain in various regions. Of course, big vascular disease results in strokes, but small vascular disease can be very, very insidious and can look like a degenerative disease. And then we have to be humble. We haven't discovered everything, the end-all be-all of the brain. I'm sure there are other factors that contribute to it. So if we take this and we say, this is Alzheimer's disease, very important. If we attack amyloid, we attack tau, we're probably getting a good distance of the way home, but not necessarily all the way home, because these other factors may be impacting the disease more or less in a given individual. So here's the picture shrunken down. What are we doing in the field now? We're trying to identify biomarkers for each one of these components, whether it's an imaging biomarker, a cerebrospinal fluid biomarker, a blood biomarker. We're trying to see to what extent can we measure the impact of each of these proteins as we go down the street. Why are we doing that? Because ultimately we'd like to develop therapies. A therapy focused on each of these individual pathologic features of the disease through the biomarkers. So at the end of the day, when you have a 76-year-old person who's cognitively impaired, we could do perhaps a panel of blood tests that could tell us that this person has an element of amyloid, an element of tau, Alzheimer's disease, but may also have an element of, say, TDP43 or alpha-synuclein. We would then design therapies, a therapeutic profile for this individual, and we'll ultimately end up using combination therapy to treat these disorders. But Alzheimer's disease is a very important component of this total picture. So let me stop there, and I'd be happy to entertain any questions regarding this complex picture, but where we are in the field of Alzheimer's disease. So Dave, thanks very much for the opportunity.
Ron, thank you so much. That was fantastic. I would encourage everybody to unmute themselves if you want to ask a question, or you can also use the chat box down at the bottom of your screen and type in your question if you wish. So any questions for Dr. Petersen?
I have a question. I'm Michael Jasons. I'm a retired professor of neurology from University of Tennessee Health Science Center in Memphis. My question is regarding the tauopathies. Clearly, tau is part of the disease process in Alzheimer's disease. But how much different is the pathology or the mechanism compared, let's say, with frontotemporal dementia? Are they two related or totally different?
Excellent question. Thank you. I mean, they are related tauopathies, but the isoforms, the type of tau, may be somewhat different. In Alzheimer's disease, we characterize the pathology as what's called a 3R, 4R, depending on the repeats in the particular tau protein. In some of the primary tauopathies, frontotemporal dementia, PSP, things of that nature, they may have, say, a pure 4R tauopathy, so that the therapy may be slightly different. There may be some overlap in therapies, but I know in the biomarker side of the house, when we're doing imaging, most of the two major imaging tracers, PET scanning tracers that are out there right now, are more specific for the 3R, 4R tau seen in Alzheimer's disease, are less specific for the primary 4R alone, 3R alone tauopathies. But there's likely combined pathology between the different tauopathies that may be overlapping with regard to the development of therapies, but they're not exactly the same as you suggest. Thank you.
Ron, there's a question here. Will the new definition of Alzheimer's disease likely be limited to the amyloid and tau biomarkers only?
It's a good question, and I must say that the new proposed framework, research framework now, is out there, but not uniformly adopted or accepted by people because is Alzheimer's disease just amyloid and tau? And I think where we get into issues with regard to the terminology, the semantics of it. Most of us, as we've grown up over the last several decades, think of Alzheimer's disease as the person with cognitive impairment, needing assistance, and that's the Alzheimer picture we have in our mind. But what this group is trying to say now, well, that may be part of the picture, but may not be the whole picture. So what the group is suggesting is that Alzheimer's disease be restricted to just amyloid and tau. The last set of slides I put up saying the whole picture of cognitive impairment imaging might be more complex than just Alzheimer's disease. But the proposal is that Alzheimer's disease be restricted to just amyloid and just tau.
Another question here, Ron. Does having MCI inevitably and ultimately lead to full-blown dementia?
Another good question. Not always. In fact, MCI, mild cognitive impairment, is a syndrome. What do we mean by syndrome? A collection of clinical features that the person has. Dementia is a syndrome, a collection of features that's more impaired than mild cognitive impairment, just a clinical collection of features. The next question we ask then is, what is the syndrome, mild cognitive impairment or dementia, due to? And this is where we get down to the Alzheimer's disease biology, but it could be due to vascular disease. MCI could be due to psychiatric conditions. If a person has a profound dementia, anxiety disorder, they could be cognitively impaired, constituting mild cognitive impairment. Mild cognitive impairment could be due to drug side effects in older individuals. So mild cognitive impairment often refers to a prodromal stage of dementia, but not always. And occasionally there are treatable features of mild cognitive impairment. If you detect the underlying cause of mild cognitive impairment to be something that is remediable, you could treat that and the person may go back to normal. But in general, when you're talking about the population as a whole, people with mild cognitive impairment will progress on to dementia at a rate of maybe 10 to 15% per year. But again, depending on the population, depending on the study. But there are those cases where if you find a cause for it, maybe an infection or something of that nature, they may in fact improve.
Terrific. Ron, I have two questions here that are related. So let me read them both to you. Can you talk about what we currently know about heredity in Alzheimer's disease? And related to that, my husband was diagnosed with MCI at the age of 59 years and then Alzheimer's disease. What can you tell me about the risk of this disease for our children?
Sure. Important question. So heredity, yes, in Alzheimer's disease, in general, we talk about two forms of the disease. Truly inherited disease, relatively uncommon, rare, but important, where there are some mutations in some chromosomes or some genes that in fact determine the disease. Those are relatively rare, maybe 1%, 2%, 5% of Alzheimer's disease is truly in that what's called autosomal dominantly inherited variety. If you get those genes, you will get the disease almost 100% of the time. Those tend to be in relatively rare, younger onset conditions where it's noted in the family that if you look back over generations, 50% of the people in the generations will have the disease. That's autosomal dominant disease. Very important because we need to understand the biology. What is it about those genetic predispositions that leads to the disease almost inevitably? So there's a very important, but again, a few percent of all Alzheimer's disease, but younger onset. In an individual who gets the disease, say MCI at age 59, that's youngish onset. So the first question you have to ask is, what about that person's family history? Other people in the family, mother, father, brothers, sisters, grandparents, did they get an onset of clinical impairment, dementia, early in life? That would suggest there may be an inherited tendency, and there are genetic tests that can be done to determine whether in fact this runs in the family. I would suggest genetic counseling in that situation, especially if the MCI then progressed on to dementia, presumably due to Alzheimer's disease. So in those instances in which there's young onset disease, we have to think more about the genetic component. That's true for almost all of medicine. If you get a disease at a younger age, the genetic contribution is likely to be greater. So if you get heart disease, if you have a family where heart attacks occur in their 50s and early 60s, the genetic component of heart disease there is likely to be higher. Similarly with cognitive impairment, MCI, dementia, if it comes on earlier in life in those families, it's more likely to have a genetic component. On the other hand, if you have, well, I got heart disease or I got dementia in my late 80s, early 90s, well, it's likely to be multifactorial. The genetic component is less prominent in those conditions. So the same thing happens with respect to Alzheimer's disease and age of onset.
Thank you, Ron. I'll pause for a moment, see if anybody has a question they want to ask, or otherwise I'll just keep going on here. Okay, Ron, here's another question. How important is it to know what kind of dementia a patient has? And at this point, are there different treatments?
I think it is important. So again, at the syndromic level, the clinical features, MCI, dementia, I think it's important to characterize where a person is on that continuum. But then you ask the next question, what is it due to? And so if we're talking about degenerative diseases, Alzheimer's disease, the amyloid and tau components are clearly the most prominent, the most frequent, and most important. But it's important to know that because hopefully as we develop therapies that are specific for those underlying pathologies, we need to know what the specific diagnosis or what the specific cause is of that clinical syndrome. So I think it is important. On the other hand, if you have a dementia, say, that's due to frontotemporal degeneration, there may be a host of other proteins, tau, TDP-43, a variety of other contributing conditions. If it's dementia due to Lewy bodies, the Parkinsonism kind of dementia, we're going to have a different set of clinical features, a different set of pathologic biology contributing to that, and we may need to know what we might expect. In dementia with Lewy bodies, people may develop Parkinsonism. They may develop sleep disorders that are very disruptive to the quality of life. They may develop a different clinical syndrome, a different picture. They may have some visual hallucinations. They may have some delusions and paranoia that may occur earlier in the disease. So dissecting the underlying cause of the clinical syndrome, MCI or dementia, becomes very important because one, there may be specific therapies for some of those conditions, and certainly knowing what the clinical symptoms that may manifest as part of that disorder will help you address them and treat them sooner rather than later.
So Ron, that's a segue to a question that I have for you, given the fact that you've said it's important to distinguish between these dementias because there will be specific therapies. I understand that there is a therapy, aducanumab, which apparently has had positive results, and I believe a submission to the FDA has occurred around that drug for Alzheimer's disease. Is that right? Can you talk about that?
Yeah, that is right. In American Brain Foundation, the American Academy of Neurology require that I disclose that I consult for Biogen, which is the company that is putting aducanumab forward to the FDA. Hopefully it doesn't influence my comments too much, but nevertheless, that is the disclosure. So the story with this particular compound, aducanumab, is an antibody that is meant to be injected into the bloodstream that is designed to go into the brain and remove that amyloid protein. So those PET scans I showed earlier, hopefully if the drug's effective, it will reduce some of that redness in those amyloid scans. So the early data, preliminary data with regard to this drug did indicate that in fact the drug did remove some of that amyloid from the brain. PET scans before treatment, PET scans after treatment, in fact, revealed a reduction in the amyloid protein. So based on those early data, the drug company went forward with 2 large international trials, 1,600 persons in each trial, designed to see whether, in fact, this drug will remove the amyloid and improve or stabilize cognitive function in people with either mild cognitive impairment or mild dementia due to Alzheimer's disease. Well, interesting story. So over 3,000 people worldwide were involved in these studies. About a year and a half ago, March of 2019, as typically happens in these studies, a committee will look at the data midstream. An unblinded committee away from the drug company looks at the data and said, how's it looking? Is this dangerous? Is this drug going to be causing a problem? And then they also ask the question, based on the data that we look at this point in time, is this likely to be positive down the road? In other words, what's the statistical prediction that this drug study is going to be positive? So based on data that were acquired through December of 2018, the committee looked at the results around March of 2019 and said, gee, I don't think this drug is going anywhere. I don't think this is going to produce positive results. And so they stopped the study in March of 2019, both studies, in March of 2019, due to what's called futility. No way, no how is this going to be positive. But they made their judgment, a correct judgment, based on data that were acquired through December of 2018. But it took them, because of the cleaning of the data, the analyzing of the data, it took them 3 months to March of 2019 to come to that conclusion. But the study continued over that time frame. And when the company then looked at the data that had been acquired in the interim between December of 2018, March of 2019, they came to a different conclusion. They said that, in fact, one of the two studies, one of the study was flat out positive. The primary endpoint and 3 secondary endpoints were all in favor of the drug treatment. The other study was not so much. The other study basically came out negative. Now, the company went back and sliced and diced the data as they ought to do and are obligated to do, and they came up with what they think was a plausible explanation as to why the second study was not positive. And so they went to the FDA then and said, look, we found that when we looked at the additional data, one of the studies was positive, the other one was negative, but we think we know why it was negative. And so they asked the FDA for permission to file for potential approval, and the FDA looked at all the data that they had at that point in time and said, yeah, okay, go ahead and submit. We'll take a look at it. No promises, doesn't mean the drug's going to be approved, but they did allow the drug company to file data in a study that was stopped early, which is quite unusual, actually, that would happen. But nevertheless, the data said, the FDA said, let's look at the data. So right now, as of a couple of weeks ago, the company has submitted a filing to the FDA for consideration for approval of this drug. Again, we don't know what's going to happen. It's all in the FDA's arms right now. But I can just say that, and this has been publicly presented, that the positive study was impressive, that the 4 major outcomes of the study pointed in the same direction, that in fact the study looked like it was positive. The other study, though, had some problems with it. So this is the dilemma now that the FDA is going to have to sort out.
That's a potentially promising development. How about the safety and tolerability? What did that look like?
So this class of compounds, namely these antibodies that are injected into the bloodstream, remove the amyloid from the brain, are effective at doing that, but they also remove amyloid, the protein, from the blood vessels that go into the brain. And when you do that, sometimes you can compromise the integrity of the blood vessels. So a side effect of this class of treatments is that the blood vessels become leaky, and fluid will transverse into the brain, as well as possible blood and blood products, and you can get small hemorrhages or a little bleeding in the brain. So that is a recognized side effect of this. But in general, I think the side effect profile was generally tolerable. There weren't any major hemorrhages that would compromise the safety of the patients. And when they adjusted the dose of the drug, basically they could dose through this particular side effect. So not trivial, not zero, but I think the side effect profile was acceptable.
And you expect we'll hear something within the year?
I think, again, nobody knows. The amount of data that are submitted for a filing like this is absolutely enormous, and given the government, the current circumstances and all that, nobody knows. But I think, well, I don't know. I would say 6 to 9 months, maybe we should get an answer from the FDA.
Okay, thank you, Ron. I have another question here. Is there a link between diet and Alzheimer's disease? I have read that a diet higher in carbohydrates may put one at higher risk. Is this true or no?
Well, I think here we get into the distinction between the syndromes of mild cognitive impairment, dementia, and underlying Alzheimer's disease. I think there are certain dietary features that may impact the risk of getting the syndrome, MCI or dementia. Is it going to, does diet actually affect Alzheimer's disease, amyloid and tau? I think that's less clear. But I think that diet, certainly, people recommend things like a Mediterranean diet for cognitive health. And I think that is fairly well substantiated. So I think that diet, in fact, can impact the likelihood of cognitive impairment in aging, maybe even dementia. Whether it does for specifically Alzheimer's disease is less clear, but why quibble over that? If a good diet is going to keep me cognitively healthy for a longer period of time, I would support that.
Yeah. There's a question here. How about the possibility that amyloid deposition is an epiphenomena and there is a more basic pathological process such as neuroinflammation?
Yes, that's a reasonable question. And there are a lot of people out there that wonder about what is the etiology, what's the cause and effect down the road, and whether inflammation is clearly part of the amyloid tau process. So where it comes in the process is another issue, but I think that inflammation certainly is a viable target to treat, to develop therapies that might impact cognitive impairment down the road. So it's a little bit of a chicken and egg, which comes first, and inflammation has certainly been touted as a possible contributing factor to the progression of Alzheimer's disease. That's the good news, and I think that still is a viable target. However, almost every anti-inflammatory drug treatment trial, be it a steroid like prednisone or whether it be non-steroidal anti-inflammatory drugs, have largely been unsuccessful thus far. Doesn't mean we abandoned it, but it's not simple. And there, without getting too much detail, there may also be a biphasic kind of impact of inflammation on the disease, and it may be treating it early might impede the development of the pathology, but later on it's thought that inflammation may actually be involved in the treatment of the disease. That is, when you give these antibodies, you may in fact induce an inflammatory response that removes the bad proteins from the brain. So in that sense, amyloid may actually be beneficial. So it's not simple.
Yeah. There is a question here about the clinical trials you were referring to for aducanumab, and it says, how is it possible that 3 months could cause a change in the data to move from futility to a positive effect?
Yeah, good question. One is there's a great volume of data that's accumulated over that time frame. But one of the hypotheses, and again, this is coming from the sponsors, is that to get a true beneficial effect of this particular drug, you had to be at the highest dose for a sufficiently long period of time. So that 3-month window was critical in having enough people be at the highest dose of the drug for a long period of time to appreciate the reduction in amyloid. So at least that's one hypothesis, that you had a large volume of data and you had people who were at the appropriate drug level, so to speak, of the compound to produce its effect. At least that's a hypothesis.
Yeah. There is a comment here. Well, it's a question. It says, I assume 77 years of age is not early onset, right? So I guess the question is, what would be your definition of what would you refer to as early onset?
Yeah, it's a good question, actually. I think most people think 65 and under, maybe 60 and under, but in the 60 to 65 ballpark. But,
yeah,
you know, what becomes challenging, Dave, in making that determination is, what is disease onset? What is symptom onset? And so it may be, if your diagnosis is at age 62, your symptoms began perhaps many years earlier. So that might qualify. And in fact, you know, I didn't show some of the slides on the putative progression of the disease process over time, but people think that the amyloid process, the laying down of the amyloid in the brain, may occur 10 to 15 to 20 years prior to symptoms. So if I become forgetful due to Alzheimer's disease at age 70, that process may have begun when I was 55. So it's a little soft, but in general, to answer the question, 65 and under, maybe 60 and under.
Well, you raise a good point between symptom onset and diagnosis. And so can you tell us, what is the average time that it takes between the time when symptoms first begin to the time when a diagnosis is actually made?
Yeah, actually, we've been looking at that in some of our studies here at the Mayo Clinic up in Minnesota, because we have the opportunity to follow the community population in which we reside, and we've been looking at the time period of people who are normal, who then progress on to mild cognitive impairment, some of whom progress on to dementia, and we've been able to determine that it looks like there's what we call a dwell time. How long is a person in that particular clinical condition, of maybe 3 to 4 years from, say, mild cognitive impairment to the development of dementia, and then dementia goes on. Now, maybe a better response to that question is, what's the time between, say, diagnosis and death in Alzheimer's disease? And again, diagnosis here refers to probably dementia due to Alzheimer's disease. And there you're talking ballpark figure, very broad, 6 to 8 years. But we certainly, you and I have seen people who have been diagnosed and may live 10 to 20 years with the symptoms of the disease. Now, their quality of life deteriorates over that time frame, but there are wide confidence intervals around those figures.
There's another question here, Ron. Other than the medication you talked about, and perhaps other medications we didn't talk about, are there any other therapeutic treatment possibilities that are promising, that look promising to you?
Well, there's a good deal of work going on now with lifestyle modification. So not the pharmaceutical side of the house, but what about the lifestyle side of the house? So we talk about exercise, we've mentioned diet a little bit, intellectual activity, social connectedness. We certainly recommend that people engage in all of those spheres when they have the diagnosis of mild cognitive impairment as well as dementia. And, you know, again, I think physical exercise, and here we're talking about aerobic exercise, maybe some strength training as well. The data are probably the strongest there that indicate that if somebody engages in an exercise routine on a regular basis, and we don't have to do marathons, we don't have to do triathlons, but say brisk walking, ballpark figures, maybe 150 minutes a week, 30 minutes 5 times, 50 minutes 3 times, may in fact have an impact on the rate of progression. It's not going to prevent things, but it may slow things down. So we certainly recommend that people engage in active exercise programs as well as staying intellectually active. Now, we don't know if brain game A is going to prevent things or brain game B, but I think staying intellectually active is a good recommendation, and I think it keeps people more engaged in life and in activities. Again, we talked a little bit about the Mediterranean diet kind of recommendations, and sometimes we throw out the term, what's good for the brain, and what's good for the heart is good for the brain, and so that kind of philosophy. And then finally, remaining engaged in your social networks, your family networks, your friends, your sphere, stay out there and stay engaged. So I think, and there are several large trials now underway with regard to this type of recommendation. There's one that's being sponsored by the Alzheimer's Association right now. It's called a Pointer study, which is based on the finger study, which came out of Scandinavia in Sweden and Finland, demonstrating that people who had an increased cardiovascular profile, they had some of the risk factors for cardiovascular disease. If they in fact engaged in a diet, exercise, intellectual stimulation, that their risk of developing cognitive impairment was reduced, not zero, but was reduced. And based on that, now there are several international programs that are addressing that, and the Pointer program here in the US is one of those.
Fascinating. Does anybody else have any other questions for Dr. Petersen? Well, those were some just fantastic questions. Ron, that was superb. Thank you so much for doing that tonight. I told you all that you're hearing from the best tonight, and I'm very grateful for you giving up your evening to spend the time to be with us tonight. And
Thanks
I
very
also
much, Dave. I appreciate the opportunity from the American Brain Foundation also to share some of these thoughts with you. By no means the absolute answers, but at least hopefully stimulate some of the thinking about this.
Well, it shows you how far we've come already with the research that's been done, to the point where now we have an FDA submission for a possible therapeutic. So it shows how promising the research has been, and what we can do and where we can get to with good research. To that point, I want to thank you all, because I know all of you tonight are donors to the American Brain Foundation. So, we can't thank you enough for the contributions that you've made to the foundation. You can see the kind of work that's being done, and you can see the results that we can get to with good research. So we really appreciate everything you've done and everything you've given to the foundation over time. And I also want to say that if you have any further questions after you reflect on tonight's discussion, if you have any further questions, please send them in to Lisa Dahlberg, who on my screen is in the upper left, or Jane Ransom, who's our executive director, or to me, and we'll make sure that we get your questions answered. And we may pester Dr. Petersen to answer a few more of your questions. So thank you again very much for joining us, and have a great night, and stay safe and stay healthy. Good night.